Hi, I'm Frank Diamond, the managing editor of Infection Control Today, where we're trying to give infection preventionists and other healthcare workers the information they need to battle COVID-19. Among those other healthcare workers are members of vascular access teams, and I have one with me today. Maya Gossman is on the vascular access team at Stillwater Medical Center, Stillwater, Oklahoma. Ms. Gossman is writing an article for an upcoming issue of Infection Control Today about the importance of vascular access teams, especially in terms of keeping an eye on peripheral intravenous lines. The article will also focus on how infection preventionists can perhaps play a part in the vascular access effort. Ms. Gossman herself works very closely with an infection preventionist at her hospital, and she's found it to be a rewarding professional partnership. Ms. Gossman, thanks for joining us here today.
Thank you for having me.
So, based on your own experience, how can infection preventionists and vascular access specialists work together to get the best results?
Well, Mr. Diamond, I am so glad that I get to speak to you
Frank,
today.
please, Frank, but go ahead.
Okay, Frank, okay. I'm honored to speak to you today about my experiences at Stillwater Medical Center. We are a community hospital, and we have 117 licensed beds. So we have a small vascular access team. There's just 2 of us on staff here that are vascular access specialists. But we do work closely with the physicians, with the nursing staff, and especially with the infection prevention nurse in order to best care for our patients' vascular access needs. There are so many factors that go into vascular access as a specialty, but I feel like probably the most important is infection prevention because it affects so much else about their care. We do place devices directly into the bloodstream of our patients, which creates a conduit for infectious agents. So we work with our infection prevention nurse to prevent any type of infection related to those vascular access devices. Specifically here, we work with her to create policy, to share data, to stay up to date on best practice standards. We trial products together that we think might decrease infection risks. She is not officially a member of our team, but we're blessed here at Stillwater to have a culture of teamwork and patient-centered care that makes us all work really well together as a team.
That's interesting that she's not an official member of your team, because that's something I've covered here at Infection Control Today. Just where do infection preventionists fit in the vascular access effort? So she's not a member of your team. Would you, if you had the power, change that in any way, or is it working fine just the way it is?
I think that as we grow, an infection preventionist on the team would definitely be a benefit. We just started our team here 2 years ago, so we're kind of a baby team.
Okay.
We used to have a PIC team that we did PIC lines on the side, and I was a part of that team. But we didn't have a holistic vascular access focus. We would do a PIC line when needed, but there was nobody focusing on the peripheral IVs, the arterial lines. There was no daily rounding by specialists on the central lines or any of the lines. So we formed that team 2 years ago. So we're just in the beginning stages, and I think as we grow, we definitely will have a place for an official infection preventionist on the team.
Give me an idea, when you call your infection preventionist in to help with something, what is it that you usually call? It's a her, is it a she?
It's a her, yeah. She's
What is it that you usually call her in to help you with?
We look at new devices. We look at new dressings, things that we think could help with decreasing infection. We actually don't have any CLABSIs at Stillwater. We haven't in 5 years, I believe. Yeah, so like I said, we're very blessed here. We're probably not the norm. I know, in fact, that we're not the norm. So we mostly work at preventing a problem from happening. One of the things we did work together with when COVID hit was, we were looking at how to prevent infection, and also these lines that we're placing in the patients are staying longer. Our COVID patients' length of stay is longer than a normal patient. And in order to minimize exposure with staff and save PPE, we were doing some things like placing the pumps farther away than we normally would from the patient. So we looked at a device that we had actually been trialing and we went ahead and adopted a securement device that's a subcutaneous securement device for our PICCs and our central lines in order to make sure that line stays in place. Because every time a line comes out and you have to place another line, that increases your infection risk in that patient. And we worked with her on that, and we've been using it with great success. So just things like that.
You can't have a discussion about healthcare these days without COVID coming into it, right? I mean, it's there, it's everywhere. But it's interesting you say that the lines stay in longer for the COVID patients. On average, do you have like an average about with that or?
I don't have a number off the top of my head, but I know that our length of stay and the length in the beginning when we were intubating more, because this was, as you know, this was new for everybody.
Right.
And it was like being thrown into a war zone all of a sudden. So we were intubating more in the beginning, and they would stay intubated for quite a while, and they would need paralytics, and sometimes they would need medications to help their blood pressure maintain, and so they would keep those lines longer, and also need more invasive lines than what we normally would do.
And when was your biggest spike?
Our biggest spike actually was in July. We had a little spike in March, and then we didn't have anything for quite a while, and then it picked back up end of June and into July.
After July 4th, I understand July 4th was a big weekend for people getting infected, unfortunately.
Yes, we're a college town as well, and a lot of our students came back. They had been gone, and they came back because leases started June 1st on apartments. So they came back into town, and they weren't the ones getting really ill, but they were spreading it quite a bit.
Now, what's interesting about COVID and the other pathogens that you usually have to deal with is COVID's a virus. The other ones are, for the most part, bacterial. Is that a correct assumption?
Yes.
Does that make it more complicated to deal with, or you just gotta deal with it the way you would usually do?
From a vascular access standpoint, it's probably about the same. We just want to ensure good access for the medications that they need. And while they might not be needing antibiotics with a virus, there are other medications that we have been giving. They may need fluids, they may need vasopressors, the medications for when they're intubated to sedate them, and paralytics. So I don't feel there's a big difference from our perspective.
How can an infection preventionist at other hospitals or anywhere develop a better rapport with the vascular access team, and what's in it for them? I hate to say what's in it for them. The health of the patients is what it's in it for them. But I guess, for one of a better phrase, what should motivate them to do that?
I think that creating a good team is important for our patients and for our work relationships. Because when you have a teamwork atmosphere, you trust each other, you know that you're always looking out for the best interests of the patients. So there's none of the questioning like, well, what's your motivation? If you know that everyone is working toward a common goal, and that's to have the best outcomes for our patients in the end, to have them get out of the hospital and go back to their regular lives and health without any complications, without a longer length of stay due to an infection that was contracted here in the hospital. So it makes everything run smoother for the patients, for the hospital. It can decrease costs, which, cost is always a factor in healthcare. If we can prevent the infections and place a single device, that's one of the focuses of vascular access, is trying to place the right line in the patient at the right time the first time, to ensure that we don't have to continue replacing IVs every 2 or 3 days. And then 6 days into their stay, we decide, oh, they need a PICC line now because, they need long-term antibiotics or whatever reason. We try to get on that from the beginning and place that line in the beginning, so it decreases costs, it increases patient satisfaction, increases staff satisfaction, because having an IV complication can derail your entire day as a floor nurse. I started on the medical floor, so I understand what that's like when you have a lot of overwhelming things going on. To have an IV complication come up can derail your entire morning. So working together, all of us together, is really in the end just to get the patients back to health as quickly as possible.
I know you and I, we had a back and forth before the interview here, and you mentioned that you are lucky enough to have developed a great relationship with your infection preventionist there. Did that just happen? Was that just chemistry, or is it something that anybody can do, no matter who the two people are?
I think that anybody can do it. I mean, maybe with a few exceptions, but I think that if we really keep the patients at the heart of everything that we do, and we set our own feelings sometimes, there are people that everybody works with that maybe they're not your favorite person, your personalities don't mesh, but as long as you...
Say that about me, man.
No. As long as you keep the patients at the heart of what you do, I think everybody can develop that trust and that rapport.
Now, let's get back to the team aspect and infection prevention on a team. I don't know if you can answer this. I don't know if this is your bailiwick, but if an infection preventionist was on a vascular access team, would that take her away from other things that she needs to do? Is it just not logistically possible to have her as part of the vascular access team?
I think that you would, wow. I think that if there was an infection preventionist on the team, she would definitely have to focus on vascular access at least part of the time. It is such a large specialty now. I mean, we have a very small focus, placing devices into the bloodstream.
Right.
However, there's so many choices now, and there's so many factors that go into the device selection that we make, that she would have to spend quite a bit of time focusing on that. So for places like here, where we just have one infection control nurse who has so much to do. I mean, she is, especially with COVID now, overwhelmed with so many things to do, that to try and have her as an official member of our team at this point would probably not work. We would probably have to have more than one infection preventionist.
Where do you see it going after COVID? I mean, this is assuming that COVID ever leaves us. We're all will there be permanent changes made to how vascular access teams operate, you think?
I hope so. One of the things I've noticed with COVID that I don't want to say it's been a benefit for me, but a positive, I guess, is that we didn't have to report CLABSI anymore, which, as I said, we don't have a problem here with CLABSI.
Right.
However, I know some places, their physicians are so focused on preventing CLABSI that they are asked to place peripheral IVs sometimes in situations where a central line would be more warranted in order to prevent CLABSI. I strongly believe that any device that goes into the bloodstream is a risk for creating an infection that could be life-threatening for that patient. So I feel like we should look equally at all vascular access devices rather than putting so much focus on the central lines as infection sources. So COVID took that aspect away for a little while at least. So we've been able to place the most appropriate line that we feel the patient needs, regardless of what numbers we have to report.
So any final words of advice for not only vascular access specialists out there, but also our infection preventionist viewers about the benefits of working together and maybe how they can make that happen?
Well, I think it's just important that we always do what's best for our patients. And anytime that you break the skin and you place a tube, I tell people I put tubes in veins. That's what I do for a living. Anytime you break the skin and you place a tube into the bloodstream, that's a huge risk for infection. And if we work together to prevent that, and we're all on the same page and a part of the same team, then we can do what's best for our patients.
Thank you so much for visiting Infection Control today.
Okay.
Maya is writing an article for an upcoming edition of Infection Control Today, and we're looking forward to seeing that. Stay safe and good luck in your worthy endeavors.
Thank you. You too.